Hello everyone, my name is Rafiq Kandi. Today we will be discussing about multiple sleep latency testing, or in short MSLT. The objectives of the today's talk includes to describe the MSLT procedures including patient preparation, test protocol and scoring guidelines, identify common challenges and troubleshooting tips for the MSLT, and how to interpret MSLT results and their clinical significance in sleep disorders based on the ICSD 3TR guidelines. There is no financial or non-financial conflict of interest to disclose. Now, the MSLT test or the MSLT is the gold standard for assessing pathological sleepiness. It is done to get two important findings, which are the mean sleep latency and the presence of sleep onset REM period, or otherwise called as a SORMs. These two items, two tools together, guides the diagnosis of excessive daytime sleepiness, as in the case of narcolepsy or idiopathic hypersomnia, etc. When performed under the strict conditions, the MSLT becomes one of the most valuable diagnostic tools in sleep medicine. Let's start with some basics. First, what is sleep latency? The sleep latency is simply the time it takes from lights out to the first epoch of any stages of the sleep. So, what is the normal sleep latency? It's usually about 10 to 20 minutes. If it is shorter, it suggests that excessive sleepiness. If it is prolonged, it suggests insomnia or circadian issues. Generally, anything more than 30 minutes is considered delayed. Next, what is REM latency? So the REM latency is the time from the sleep onset to the first epoch of the REM sleep. Normally, it is about 90 minutes. Usually said something between 70 to 120 minutes on a nighttime PSG. If it is shorter than 60 minutes, we start to think about sleep deprivations, medication withdrawals, depressions, even narcolepsy. But the SORM, the sleep onset REM period, which means the REM sleep occurring within the first 15 minutes of sleep onset, either during MSLT nap or even during the the baseline PSG. So this is a key diagnostic feature of narcolepsy. It doesn't mean that it only present in narcolepsy, but it sometimes may be seen in severe obstructive sleep apnea patients, withdrawal of antidepressant drug, even depression patient, or even in narcolepsy. So you can see here, this is the sleep hypnogram. This is the lights out and the first stage of the sleep N1 in this example. This is the sleep latency, and from there the first epoch of the REM sleep. This is the REM latency. So usually this is 70 to 120 minutes. This is around 10 to 20 minutes. Now, what is mean sleep latency? Mean sleep latency is the average of the sleep latencies of all the naps during the MSLT. Generally speaking, there will be 5 naps. You take the sleep latencies of nap 1, nap 2, nap 3, nap 4, and nap 5 and divide it by the number of naps. The shorter the sleep latency, greater is the objective sleepiness. Now the question is, the excessive daytime sleepiness can come from several categories, right? One is simply the insufficient sleep or the poor sleep, as seen in the insomnia, poor sleep hygiene, circadian rhythm disorders, etc. The second one is the fragmented sleep disorders, as what we usually see in the sleep-related breathing disorders, where there is a frequent awakenings and arousals, or even in the movement disorders, parasomnias, etc., where the sleep continuity is disturbed. Or as in the case of increased need of a sleep, or a primary hypersomnia, as in the case of narcolepsy and idiopathic hypersomnias. Or even it can happen due to medications or medical causes like stroke, epilepsy, depression, chronic kidney disease, cardiac disease, etc. So, the when next time you see an excessive daytime sleepiness, don't stop at that score. Ask yourself, which bucket does it fall into? So, how we do the assessment of this excessive daytime sleepiness? The excessive daytime sleepiness can be assessed subjectively and objectively. The most common tools used for excessive daytime sleepiness is the Epworth sleepiness scale, which everyone knows that there are 8 situations, each of which can be graded from 0 to 3 based on the level of sleepiness which the patient was experiencing within the time, like a few days to few weeks. Higher the number, more than 10, is considered to be sleepy, and the lower, less than 10, is considered normal. Another subjective sleepiness is that the Stanford sleepiness scale, where there is 8 questions, and how you feel now. This is like a snapshot in time. So how sleepy you are now. That's a question of Stanford sleepiness scale, whereas the ESS is just like an overall sleepiness feeling, few days to weeks. Now, the problem with the subjective level of questionnaire is that you can lie. For example, I may be wide awake, but to get a special attention, I may say, I am so sleepy, to make the ESS like 20 plus, or the Stanford sleepiness saying like 7 or 8, or the last. So that's a problem with the subjective. To make it objectively, here the MSLT and MWT comes into place. So, in short, there are 7 group of sleep disorders, as mentioned by the American Academy of Sleep Medicine's International Classification of Sleep Disorders, ICSD-3. We have a text revision recently, and as per that classification, there are 7 group, and the third one is called as the central disorders of hypersomnolence. That is again subdivided into different categories like narcolepsy type 1, narcolepsy type 2, idiopathic hypersomnia, Klein-Levin syndrome, etc. Again, insufficient sleep syndrome is also part of that classification. So, what's happening is that the MSLT is generally used to diagnose or to rule out this central group of disorders. So when we are coming to the actual MSLT testing, the patient preparation starts way ahead. The results will be valid only if the patient is properly prepared. Without a proper preparation, the test results can be misleading. So the preparation starts at least 2 weeks before the test, as in the case of documentation of the sleep diary, or for that matter, using an actigraphy, which gives the actual sleep wake schedule. Then there should be the stability and treatment efficacy of OSA. If the patient is already been diagnosed with the OSA, and the patient is prescribed for a CPAP or a mandibular advancement device or any other form of treatment, patient should continuously be adherent, compliant with the treatment. Otherwise, the test results will be misleading. And the another important thing is that the medication management, the stimulant, sedating, or REM sleep modulating property drugs should be discontinued. For example, the antidepressant medications, it can suppresses the REM sleep and has to be 2 weeks at least before the test. It should be stopped. There are some antidepressants where the half life is more than 1 day. It needs to be on hold for more than up to 6 weeks. If you read the Kranz et al. ASM practice guideline for the MSLT and MWT. And this is an example for the sleep diary, where the patient have to document at what time he starts sleeping, at what time he woke up, at what time he have the coffee, tea, or when he do exercises and or any other activities. And on the day of the test or the night before the test, there should be an in-lab attended PSG, which allows a minimum of 7 hours of time in bed, or with at least 6 hours of sleep. So now we are talking about the adult sleep MSLT. Okay, the MSLT after the split night or a post titration study is not recommended. Wearing a comfortable clothing appropriate for the environment. There was a previous MSLT MWT recommendation that the patient needs to be changed to the street clothes, but it's no longer required. Abstain from the alcohol, caffeine, marijuana, nicotine, or other agents affecting the alertness or the sleep on the test day, and patient should use their regular PAP or a non-PAP, for the example the MAD, mandibular advancement device, during the PSG night before the MSLT and during the MSLT naps. And it has to be recorded or documented in the patient file. So you need to do the PSG on a CPAP if the patient is already on CPAP, and the nap should be on CPAP as well. So ensure that the sleep rooms are dark, quiet, and comfortably tempered. Have the patient lie in bed for all nap trials, and conduct the specific biocalibration before each nap trial. Nap instruction should be unique and give the same instruction at each nap. Position yourself, close your eyes, and try to fall asleep. And now let's do the MSLT trials. So usually 5 nap trials are conducted. The first nap usually starts from 1.5 hours to 3 hours post PSG, which means that, for example, if the patient's sleep study ends at 6 a.m., the first nap can be started as early as 7:30 a.m. or as late as 9 a.m. And from the first nap, start every 2 hours thereafter. For example, if the first nap started at 8 a.m., then the second nap would be 10, 12 p.m., 2 p.m., and 4 p.m., and that's it. There can be a 4-nap trial, or the shortened version of the MSLT can be done, which we'll be discussing down the road. So now the question is, what is the MSLT montage required? The montage contain the sleep parameters, which are the EEG, EOG, and EMG, supplemental EMG, and EKG for the safety purposes. Remove all the unnecessary sensors like respiratory belt, PLM sensors, etc. can be removed. Continuous audio-visual recording during the nap trials and monitoring throughout the day is required. And offer the restroom use and address other comfort needs before each nap trial, so that get prepared ahead of the nap trial so that there will not be a delay, because the MSLT is a time-bound procedure. This is an example of the MSLT montage. We can see that the eye channels are there, the right and left eye, and the EEG channels for the sleep pattern, and then chin EMG for the EMG signals, and then ECG is recorded. We need to document. We can use a documentation form as if like this, which will help us to plan the MSLT naps, at what time the sleep starting epoch, ending epoch, and the sleep onset, and then add 30 epochs. So usually using this form help us to get easy understanding of the MSLT procedures. Now, the sleep onset and REM onset in MSLT, how it is scored. The sleep onset is the first epoch of any sleep stages. It can be N1, N2, N3, or even REM. It is measured from the lights out. That means the lights out to the first epoch of sleep. The REM onset, similar to the nocturnal PSG, the time from the sleep onset to the first epoch of REM sleep. And as I discussed earlier, the SOREM means REM within 15 minutes of the sleep onset. So this is how the stages sleep MSLT naps are scored. The scoring is more or less the same thing as the nocturnal PSG. Now, how to end the nap? Now, what we are doing is like we have prepared the patient 2 weeks in advance, and then we have done an overnight PSG night before the MSLT. The study stopped in the morning. Now you start the sleep study MSLT first nap within the 1.5 to 3 hours, and now you have started the first nap, and you started scoring the sleep stages as discussed above, that is a sleep onset and REM onset. Now the question is where you will end the first nap. Usually, if there is no sleep after 20 minutes, terminates the nap. If the patient falls asleep, you have to continue recording for at least 15 minutes from the sleep onset. Why? Because to see whether the patient is having REM onset or not. Once a patient is having a sleep onset, we will get the mean sleep latency, and then from there, the sleep latency, and from there we are waiting to see whether there is any REM onset. If there is REM onset, the SOREMs continue until the total 15 minutes of sleep. There is no correct guidelines. So there are some arguments like once we have a REM sleep onset, we need to immediately wake up the patient, but there are no correct recommendation. Generally accepted rule is to continue till 15 minutes. Wake the patient gently and document the sleep latency and REM latencies accordingly as given in the previous documentation form. Now, we have completed the first nap. Then what happens is that based on the start of the first nap, for example, if this nap is started at 8 a.m., we will start the next nap at 10 a.m. Between the nap trials, what the patient have to do? Limit the stimulating activities and avoid vigorous physical activity, and avoid the bright light exposure. Keep the patient out of the bed and awake. Sometimes it may be very difficult to keep the patient awake, especially because the patient is excessively sleepy. So you may need to find a way or be with the patient and keep the patient awake. Provide another thing is that you have to plan the breakfast and the lunch well in advance, so that at least there is a 1 hour gap between the breakfast and the first nap. or between the lunch and the subsequent naps. Drug screening, sometimes physicians do request for that and has to be done to ensure there are no confounding substance use. Now, let's say we have completed nap 1, nap 2, nap 3, nap 4, and nap 5. How you calculate the sleep latencies? So it is the sleep latencies of all naps. For example, we have given some numbers here. The first nap sleep latency was 5 minutes, second was 4, third 6, 6, and 4. So the total is 25 minutes, which is divided by 5 is equal to 5 minutes. So now the question is, we got a number, 5 minutes, what that means, what that number tell you. So as I discussed earlier, the MSLT is done to find out two important findings. One is mean sleep latency, which is calculated as discussed earlier, and to find out whether there is a sleep onset REM period or not. So the normal sleepiness is mean sleep latency greater than 10 minutes, and there is no SORMs. That means patient is normal. There is no excessive daytime sleepiness. The EDS, idiopathic hypersomnia, narcolepsy, etc. is somewhat ruled out. If the mean sleep latency is between 8 to 10 minutes, it is borderline. There is a propensity, increased sleepiness. There you may see some 0 to 1 SORMs here or there, something like that. That is in the borderline range. If the mean sleep latency is less than 8 minutes, it is pathologically sleepy. So the situations are either it can be narcolepsy or it can be idiopathic hypersomnia. How to differentiate between the idiopathic hypersomnia or narcolepsy type 1 or type 2? So in narcolepsy, the mean sleep latency will be less than 8 minutes, and there will be presence of 2 or more SORM in the MSLT naps, or 1 PSG MSLT SORM, one PSG SORM plus 1 SORM in any of the naps in the MSLT. So in both way, either 2 SORMs during any of one of the 5, 2 of the 5 naps, or 1 SORM in the nocturnal PSG, and then 1 in the one of the naps is qualified for narcolepsy. If the mean sleep latency is less than 8 minutes, but there are no SORMs or the SORMs are less than 2, it is idiopathic hypersomnia. So now the question is, what is narcolepsy? We are not going into details about the narcolepsy. There are generally, before we call it as the tetrad features, excessive daytime sleepiness, sleep paralysis, hypnagogic or hypnopompic hallucinations, and cataplexy. Now, the fifth one is also added to make it pentad. It is the fragmented nocturnal sleep. And other factors like automatism and memory issues and mood disturbances also can be associated with narcolepsy. Now, there are 2 types of narcolepsy. That is narcolepsy type 1 and narcolepsy type 2. In either case, as we discussed so far, the mean sleep latency will be less than 8 minutes, and there will be 2 SORMs, either 1 SORM in the nocturnal PSG and 1 SORM in the MSLT naps, or 2 SORMs in the MSLT naps. Plus, if the patient is having the cataplexy, which is the muscle tone loss for emotions, most of the time to the positive emotions like laughter, happiness, joy, any type of positive emotions and sometimes anger. If the patient feels loss of muscle tone, it is called cataplexy. Sometimes patient may have a typical cataplexy where you don't fall to the ground, but there may be like eyelid closure or neck or jaw drops or dropping things from the patient hand like that. That also can be a sign of atypical or a sign of cataplexy. So narcolepsy diagnosis by the MSLT plus the presence of cataplexy will be the sign of is considered to be the part of the narcolepsy type 1. And if you are doing the CSF hypocretin level, it will be less than 110 picograms ml. Now, the MSLT testing is less than 8 minutes, and there are more than 2 sorums, but there is no cataplexy. It is called as narcolepsy type 2, and the CSF and CSF hypocretin level will be greater than 110 picogram, generally speaking. Now, idiopathic hypersomnia, as discussed earlier, there will be less than 2, maybe 0 or 1 sorum, but the mean sleep latency is less than 8 minutes. Let's review a patient MSLT. Now you can see this is the nocturnal PSG hypnogram. You can see these are the REM sleep, and yellow are in the N1, green is the N2, and this blue is the N3 sleeps. We can see that the patient was sleepy from the lights out itself, and there is a REM sleep onset. You can see here. This patient is an age 14 years with a BMI of 35, neck circumference of 41. Total sleep time for the nocturnal PSG was 380 minutes, sleep latency 0 minute, as we discussed earlier. REM latency is 5 minutes, sleep efficiency was 85%. N1 was slightly elevated at the cost of REM sleep. Total AHI was 4 only. Patient presented with excessive daytime sleepiness, sleep paralysis, hallucination, and cataplexy. Classic sign of narcolepsy with the presence of cataplexy. If there is MSLT diagnostic, it will become type 1, narcolepsy type 1. The study ended at 6:30 a.m. So as we said, the first nap can be started at 8 a.m. as early or as late as 9:30 a.m. Now, this patient had REM sleep in the first nap, sorums in the first nap, sorum in the second nap, sorum, there was no sorum in the third, and again a sorum in the fourth nap. So the shorter 4 nap trials can be done if the diagnosis of narcolepsy by the presence of mean sleep latency less than 8 minutes and the presence of 2 or more sorum alone in the MSLT, or 1 MSLT sorum plus 1 MSLT PSG sorum. So if you have that classic confirmation, we can end at 4 nap. If not, 5 have to be completed even if there was no sorum at all. So here the mean sleep latency was 0.6 minutes. You can see, as you can see, the lights out, it was very immediately patient had sleep onset, and there were like 3 MSLT sorum and 1 PSG sorum, altogether 4, and it is a classic. Along with the presence of cataplexy, this is diagnosed as type 1 narcolepsy. So for this patient, you can see the epoch number 64 is N2, 65 is again N2. If not REM sleep, you can see there was some like slow eye movement here, a little bit eye movement here as well, but there is signs of N2 here. And you can see the epoch number 66, classic rapid eye movement, and 67 also. So just to show you how quickly this patient went into SORM or sleep onset REM period. Now, the study 2, the female, 48 years old female, there is not a shift worker, no history of RLS, no delayed sleep phase syndrome, no symptoms suggestive of depression, thyroids are within the normal limits, occasional snoring, excessive daytime sleepiness of 18, no history of cataplexy, sleep paralysis, but there are some vague signs of hypnagogic visual hallucination for the past 1 year, mostly involving the visualizing of her son who had died in a car accident. Not on any medication, patient have claimed that 7 to 8 hours of sleeping, and the sleep log was documented with some additional sleeping during weekends. The MSLT, PSG was done prior to the MSLT. Total sleep time of 405 minutes, almost 7 hours. Sleep latency was 32 minutes. REM latency was 80 minutes, which is normal. But sleep latency was slightly delayed. AHI is only 2.6 per hour. Lowest SpO2 is 92%. All looks normal, slightly reduced M3 sleep as well. Arousal index is slightly elevated, but it's still in the normal limits with given the age, and the PLMX index is also fine. Now, this is the hypnogram for that patient. You can see there were no sleep onset REM period, and MSLT was done. 1, 2, 3, 4, and 5 naps were done. As discussed earlier, there were no SORM in the PSG, and there were no SORM in the MSLT, and hence we have to complete all 5 naps. Here, the mean sleep latency is 4.9, which is pathological, less than 8 minutes, and hence this patient's can be classified as an idiopathic hypersomnia. Now, as we have discussed 2 cases, now let's discuss about some of the troubleshootings which we encounter while doing MSLT. Now, let's look at this MSLT. Now, this patient had no SORM in the nocturnal PSG. The sleep study ended around 6:30. The patient was awakened immediately in the middle of a REM sleep. Now, the problem is, like, if you wake up the patient from a REM sleep, and as in this case of the first nap, you can see the REM sleep is there, SORM is there. Now, the problem is it a question of whether it is a direct extension of the interrupted REM sleep, or is it a true SORM? There will be such a question. Always during MSLT, the first nap SORM is always to be counted with caution that it may be an extension, or it may be within those, patient's natural sleep time, especially if the patient has a delayed sleep phase component, and hence this will be a difficult situation, especially given because of this waking up from the middle of the REM sleep. But for this patient, there had 2 SORMs again, but it will give us a clear indication for the diagnosis, along with the clear signs and symptoms. But always try not to wake the patient from the REM sleep. Wake the patient if in any other stages of sleep other than REM sleep. Now, in this patient also the same question. The patient was awakened, but the patient was awake for a long period of time before the sleep study was ended, but again, it was slightly woke up from a REM sleep. This patient have almost 30 percentage or more REM sleep with very minimal interruptions during these are the gray are the wakes, so sleep efficiency is almost 97 or 98 percentage. There are no significant respiratory problems, and we did MSLT. The patient was like this. We did 5 naps. So the question is, even though there was no sorum in the nocturnal PSG and there was no sorum in the naps, why we need to do the fifth nap? The answer to that is MSLT is done not only for the sorums, it is also for mean sleep latency. So the mean sleep latency may be affected by several factors, and having the fifth nap may give a shorter mean sleep latency for the correct diagnosis, or sometimes it may give a longer sleep latency and excluding the pathological sleepiness. And hence, completing the fifth nap is essential. Don't get focused only on sorums. Now, this is another case where you can see there was no sorums. We have 5 REM sleep, and patient was awake again here before end the study. This patient had a sorum in the first nap and second nap, and in the fourth nap. In this case, again, we continued the fifth nap. Why? Sometimes we may end up doing that also. In this patient, what happened was, if you look at the fourth nap, the sleep latency was prolonged, and if we were ending here, sleep latency would have been just close to the 10 minutes in those borderline or gray zone area. What happened for this patient was, just before going to the fourth nap, it is a 22-year-old boy. His girlfriend showed up to the sleep lab, which we are not aware of. And then that made the patient to be awakened and aroused, and it took time to fall asleep. Even though there were like 3 sorums, the mean sleep latency is just around 10 minutes. And it gives us, it makes the diagnosis in a bit difficult situations. And hence, what we did was, like, we excluded this one and took this one and made it, and the mean sleep latency was within less than 8 minutes. So what I am trying to say is that anything which can alter the normal situations can change dramatically the sleep report or the MSLT report. Anything which hampers the sleepiness of the patient should be documented, and the physicians can make the diagnosis or make the interpretation correctly. Or there may be some environmental issues like big noises from the other rooms or outside, which made the patient to have a difficulty to fall asleep, also needs to be considered while interpreting, and hence proper documentation from the tech side is essential for the proper diagnosis. And these are some of the things. Now, reporting procedures. The medication and pre-sleep study data needs to be incorporated in the MSLT report, and recording parameters also needs to be reported, like the start time and end time of each nap, total sleep times, sleep latency, REM latency of each trial, etc. Sleep latency and sorums, these are the 2 things we are looking at from an MSLT, and hence it has to be clearly mentioned. And deviations and conditions, like as we discussed earlier, sometimes the patient may not be able to wean out the antidepressant. So it has to be documented, because sometimes there may not be REM sleep at all, or there was some significant noise, or for the last patient, the presence of a girlfriend, etc., needs to be mentioned in the report to make the final report clear. So this is one of an example of a sleep study, MSLT data. We can say that overnight sleep study AHI of 1.9 per hour, 2 weeks regular sleep pattern for 7 hours, cataplexy questionnaire, there was no cataplexy symptoms, urine toxicology was not ordered. The sleep latency, mean sleep latency, the overnight PSG is mean sleep latency 7.5 minutes, and REM latency within the normal, and total sleep time, etc., was mentioned. Total sleep time as well here. Here it was given only 4 naps, but it should have been 5 naps, since there is no there was sleep onset time period in 3 naps, and Stanford Sleepiness Scale was also mentioned here, and the mean sleep latency is 2.6 minutes. So presence of the as the mean sleep latency is less than 2.6 minutes with 3 naps, along with no cataplexy, becomes narcolepsy without cataplexy, or the type 2. The limitations to the interpretation of study in the first nap close to the REM from prior sleep study. So it may be the one which we have discussed earlier, that is also been addressed in the report. Now, based what are the guidelines? If you want to read more about this one, you can read this Kran et al. Recommended protocol for MSLT and MWT, the guidance from Sun, which is available for the free. And if you are working in a sleep lab where the MSLT is being done for the pediatric populations, there is a new recommended protocols by Maskey et al., which was published last year in 2024. It's a very good read. What we have discussed so far is mainly adult. If there are changes with the kids, the sleep diaries are usually sufficient for the adult, but in pediatrics, actigraphy is strongly recommended. Because sleep diaries alone are often unreliable in the pediatric populations. Sleep needs to be addressed or looked based on the children's age group. The recommended is at least 8 hours of total recording time, with minimum 7 hours. But it has to be the minimum sleep hours needs to be recorded based on the age of the patient. The nap structure, everything remains same. 5 nap opportunities and overnight PSG, etc., remain same. The adult criteria of less than 8 minutes and SORMs may not be apply directly. Interpretations request developmental context of the child. And clinical concerns in narcolepsy, idiopathic hypersomnia, and suspected hypersomnolence syndromes in children often presents with behavioral or school performance concerns rather than just EDS. All right, so that is another things to be kept in mind. And preparation needs to be more emphasis needs to be given, as in the case of like medication washout, especially for the stimulants for ADHDs, which are common in the pediatric populations. These are some of the things additional to that adult. Again, we can read this recommended protocol from Maskey et al. So the take-home message for today's discussion was, if done correctly, the MSLT is a powerful and reliable diagnostic tool. And if it is done poorly, it can lead to a lifelong wrong diagnosis. So what we discussed is the preparation is very important, and the documentation and technician input is very essential for proper diagnosis and interpretation of the results from the physician side. Any questions? If there is anything, please let me know in the chat or in the comment section. And this is your references. Thank you for listening, and let me wind up here.